Children, bigger occiput back at the head. So when we lay them flat, their head, because of how big that occiput is, it hyperextends the neck. So their neck actually now their chin comes closer to the chest, and now it can, bend that trachea, so we don't have an open airway conduit. So one of the things that we need to keep in consideration for our pediatric patients is making sure that we pad under the shoulder blades. So we're trying to bring the body up to meet the head. Okay, so that way we can keep that trachea in a nice neutral inline position. So the way this mannequin comes, we can see that this here is kind of demonstrating where that padding would be, but you would want to have padding available to you. So good things to have in your airway bag are always like extra towels. So you can use for secretions, if there's vomit, to fold up and use for padding under our pediatric patients. So just so we can kind of see, this is where now we would slide this under their shoulder blades. So it doesn't come under the head, it comes under the shoulder blades. We're trying to bring this up, and you would fold that or use additional towels to get them so that we can have them in that nice neutral position. All right, we have appropriately sized pieces of equipment. So our adjuncts, we do have NPAs that come in the correct size. You can see that that's small. Our OPA, measured the same way. We can see that this fits, and you can see how small that is. We're going to need a tongue depressor for our infants because we're not going to do any rotation on our OPA. So we remember that in our differences, pediatrics, their trachea is more flexible. It doesn't have as well developed, cartilage rings, so it's much easier to kink and bend. Their tongue is larger in proportion, to the adult patient's mouth, so it takes up more room. And this is where their lungs aren't quite as developed. So we want to make sure that when we get a PD call, our adrenaline's going. We have to make sure that we're in good control of what we're doing so that we don't cause harm, because it's going to be easy to cause barotrauma when we ventilate this patient. So we come in, we've got our patient, we've determined that we need to manage their airway, we've padded under their shoulders, get them in this neutral position. So now when we size our OPA, same, corner of the mouth to the corner of the ear, we make sure that it fits. We now take our tongue depressor, so plastic, wood, whatever it is that you have available, and now you're using this to displace the tongue. So this is now pushing this tongue out of the way so we can slide the tongue depressor straight, the OPA straight down the tongue depressor. So there's no rotation like we had in our adult because their soft palate, very vascular, and that tissue is more fragile and delicate. It's going to be much easier for us to, cause tissue damage that's going to result in bleeding. And now we're going to have to do some suctioning, and it's going to make it more challenging to manage this airway. So we want to make sure that we use our tongue depressor, we get that tongue out of the way, and then this OPA just follows the tongue depressor straight in, and it still sits so that the flange is flush with the lips. So unlike, coming in and doing that turn, we don't want to cause any damage, especially at a 180, we don't want to damage that soft palate. So tongue depressor, you push that tongue out of the way, displace it, you come straight in with your OPA, and it still sits so that flange is flush with the lips. OPA and our BVM, we have an appropriately sized, make sure we have good mass seal. So now we come and we walk it down, making sure we're not going over the eyes. Our CE clamp is the same, bringing this up to them. And now when we squeeze the bag, you can see I don't need a ton of, I'm not squeezing the bag, I'm gonna cause barotrauma. So, really I only need a couple fingers to be able to see that chest rise. Now here, obviously there's no chest, so it's easy for us to see, the balloons inflate. So when we look at our range for our ventilation for kids, we've got, one breath every 3 to 5 seconds. So for this little one, this would be, one breath every 3 seconds would be appropriate. So we give our ventilation, 1 1,000, 2 1,000, 3 1,000, 1 1,000, 2 1,000, 3 1,000, 1 1,000, 2 1,000, 3 1,000. And this is where now you need to be in check, because as your adrenaline's going, it's going to be very easy to hyperventilate and to make sure squeeze this bag kind of. When you're doing this much force, we're definitely going to cause gastric distension, and we have the ability to cause barotrauma and actually cause a pneumothorax and collapse that lung. So the mechanisms and the objective behind airway management is the same, but we do have to take into account, those anatomical differences, and then make sure that our equipment is sized appropriately for the patient we have in front of us.